Okay, good afternoon, everybody. Today's my topic is on antiretroviral therapy. So I'll be starting with the what are the goals of the treatment and what are the principles of the treatment, and again I'll be continuing with the first line of treatment. Just I'm not covering the next part like any patient is having any opportunistic infections, and again second and third line of treatment. I'm not covering that. So goals of the treatment. So in HIV patient, what will be the goals? First goal will be clinical goal, that is to increase the survival and improve the quality of life of the patient. Then virological goal. So virological goal will be decrease the viral load in the patient. Then immunological goal. Immunological goal will be increase the CD4 count. As we know, the HIV patients will have very less CD4 counts, which will lead them to get opportunistic infections. And next is therapeutic goals, that is rational sequencing of drugs in a manner that achieves clinical, virological, immunological while maintaining the future treatment options. We know that HIV is not curable, but it is manageable. So we need taking this into consideration. We need to make their therapeutic regimen in such a way that they experience less side effects of the ART regimen. Along with it, their quality of life is also improved. So these are the goals, and also there is one primary goal which is preventive goal. Preventive goal. So that is like reduction of HIV transmission. So we have to make sure that the HIV infected patient doesn't infect the other patients, or the other patient doesn't infect the HIV patient because he's already immunocompromised. So that is the goals of the treatment. Next is the principle of ART. So in principle of ART, we have different class of drugs. That is our fusion inhibitors, CCR5 receptor blockers, and nucleoside receptor reverse transcriptase inhibitors. Then non-nucleoside reverse transcriptase inhibitors, and these are the new class, that is nucleotides reverse transcriptase inhibitors. And again integrase inhibitors, protease inhibitors. So these are the primary drugs which we use in our clinical setup. So fusion, first we will go for the fusion inhibitors. These drugs stop the fusion of the HIV pathogen into our CD4 cells. So thereby it will limit the fusion of the cells and thereby decreasing the infection. So the example of this drug is Maraviroc, and the tick mark ones are those which are present, no, approved by the CDSCO, that is present in our country, that is India. And the short form, every drug has a short form. Again, we denote every drug with a 3 letter of short forms. So Maraviroc's short form is MVC. It is available in India in the form of 150 mg, and the amount for each tablet is 174.6 rupees. And CCR5 co-receptor blockers, that is enfuvited. So it is approved in US FDA, but it is not present in India, and it's still under extensive research. Then next we have nucleoside reverse transcriptase inhibitors. So these are the drugs which are present in India. No, comes under nucleoside reverse transcriptase inhibitors, out of which the double marking ones are those which is present in our hospital setup, that is in our formulary, and the single tick marks are CDSCO approved, that is it's present in India, and we use in different hospitals. So primarily zidovudin, lamivudin, abacavir, and emtricitabine is used mostly in our hospital. And in non-nucleoside reverse transcriptase inhibitors, we have nevirapine, efavirenz. So out of all these drugs, and etravirin. So these are the drugs which are primarily used, and the others, delavirdin, rilpivirine, and doravirine, are still under investigations. It is not yet approved. And nucleotides reverse transcriptase inhibitors, we have tenofovir is a primary drug actually, and the excipients are added to it is, no, the side chain added is disproxyl fumarate, and the other one is alphenamide. So what is the difference between both of it, although the same drug? So what is the need of the both drugs? So tenofovir disoproxyl fumarate will cause can cause kidney problems along with the bone loss, and also it leads to, and the advantage of this drug is that it will lead to less accumulation of cholesterol and triglycerides in the body, so thereby promoting weight loss for the patients. And tenofovir alphenamide, It has a less ADR compared to tenofovir fumarate. That is, it has less this thing kidney problems and bone demineralization, but it can cause lipid accumulation, which can contribute to weight gain. Again, weight gain will contribute to many other hazard health issues. So that's why this tenofovir disoproxyl fumarate is used more and it is preferred more. And next we have integrase inhibitors. There are actually 5 integrase inhibitors, out of which 2 are mostly used in India and the others are not yet approved in India. That is dolutegravir and raltegravir. And raltegravir was approved in 2007 in India, and in 2020 dolutegravir was approved, out of which we use mostly dolutegravir rather than dolutegravir. Dolutegravir is mostly used as a first line of treatment, and raltegravir is also used, but in a second line and third line of treatment when the first line has failed. So then we use raltegravir. And again, compare if we compare the ADRs, raltegravir has a more occurrence of ADRs in comparison to dolutegravir, which are manageable. Mostly dolutegravir has a manageable ADRs, so which can be, that's why we prefer dolutegravir more. And we have next class is protease inhibitors. So these are all the drugs which comes under protease inhibitors, out of which mostly all of them are approved in India. Only 3 of them, that is amprepanavir, fosamapanavir and tipranavir, is not approved in India, and we use mostly ritonavir, lopinavir, and also we use saquinavir. We used to use a lot, but now we don't use ritonavir and lopinavir. Again, this protease inhibitors, we have to always combine like 2 drugs to be given. That is, one will be of course ritonavir at any cost. We can combine with other drugs. Ritonavir can be combined with any other drug, because ritonavir when combined with other drugs, it causes like a booster dose. It is like a booster dose. So that will help in better control and management of the disease. So next is brands present in our clinical setup. So these are all the brands which are present. And Veropil. So Veropil is the drug which we use as a first line of treatment. Any patients we see as a HIV positive, irrespective of 1 or 2. So there are 2 types, HIV 1 and 2. So we first prescribe Veropil. That is, it comes under the packaging of 30, and the cost is each tablet will cost us around 124 mg, 124 rupees. So this is about the brands. And again, this protease inhibitors. Protease inhibitors are mostly enzyme inhibitors. So they will inhibit our hepatic enzymes. We have like enzyme inductors and enzyme inhibitors. So these are mostly enzyme inhibitors. So we need to see whether we are giving any other drugs which will be affected by the interaction with these drugs. And dolutegravir. So dolutegravir has many interactions with the other drugs when given concomitantly. So it has one drug interaction with a drug called amodiaquine. Can anybody say what class of it? Anti-malarial, yes. So when you are giving amodiaquine, so you need to increase the dose. I'm sorry. If we are using amodiaquine, then we have to use an alternate anti-malarial agent, or we have to stop the dolutegravir. So it's better to replace it with some other anti-malarial agent. And carbamazepine, if we are using, then double the dose of dolutegravir, because it will inhibit the enzymes. It will induce the enzymes. So thereby increasing the metabolism of dolutegravir, thereby decreasing the concentration of dolutegravir in the body. So that's why it's better to add one more 50 mg of dolutegravir into the regimen. And phenytoin and phenobarbital, if it is used, then change the drug. You shouldn't use phenytoin and phenobarbital along with the dolutegravir. Then dofetilide. Can somebody say the class of this drug? It comes under antiarrhythmic agents. So if it is used, then just switch to some other antiarrhythmic agents. And metformin, we know it's a very common OHA which is prescribed. So surprisingly, metformin also has a interaction with the dolutegravir. How it has an interaction in the sense is, when we are using together, the drug will dolutegravir will cause the renal excretion, increase in renal excretion of the metformin. Oh, sorry, decrease in the renal excretion of metformin, thereby increasing the AUC into two folds and also Cmax into two folds. So that's why we need to be careful and restrict the metformin dosage up to just 1 gram in a whole day. You shouldn't go beyond that because the AUC will increase again and the Cmax, and thereby leading to lactic acidosis, and it's very common area like cyanocobalamin deficiency. So that is with metformin and polyvalent cation products containing, if the patient is taking any multivitamins or any calcium carbonate supplements, antacids and all, so it will interact with those agents also. And the interaction, how is the interaction in the senses in the GI gut, it will interact with it, and so it will form a chelating agent with it. So the chelation causes the excretion of dolutegravir both and this polyvalent cations again. So this is also in effect, dolutegravir is also ineffective, it is given together. So what can be, how it can be manageable? Time spacing. Just space the time like 2 hours before the drug or 6 hours after the drug, either of it. And rifampicin, since we know rifampicin is an enzyme inducer, so it will increase the metabolism of dolutegravir. So if it is increasing the metabolism, so increase the dose of dolutegravir. So we give 50 mg BD or 100 mg OD, same thing. We need to increase up to 50 mg. So or we can substitute with rifabutin also. So that will be helpful. And again, I'll explain about few points on the adverse effects of these drugs. So zidovudin mostly it has a hematological effects, that is it has a short ADRs, immediate ADRs and long term ADRs. Short ADRs will be mostly hematological. The patient will have anemia, neutropenia, and again also will have bone marrow suppression along with intolerance, headache and insomnia. The long-standing ADRs will be hyperpigmentation of skin and the nail. And lamivudine is one of the safest drug, even if the concentration is increasing very rash, like too much, because of the patient is or either AKI or any other drug interaction. Still, lamivudine can be given because it has very minimum ADR, that is minimal toxicity. It is rash. That's all. No other ADRs have been reported in lamivudine. And next we have abacavir. It has like most of the drugs will cause nausea and vomiting and diarrhea. That's a common ADR of all. So other ADR will be like hypersensitivity reaction in abacavir especially. And efavirenz. So efavirenz should be taken at bedtime, due to the reason that the ADR, like side effects and ADR of efavirenz is that it will cause CNS effects, which will cause insomnia, somnolence, and dizziness. So it's better to take at bedtime and with less fat. Why? The reason because why to take with the less fat is because when there is a fat in the fat, when we take fatty food along with the efavirenz, it will increase the concentration of efavirenz in up to 60%. So thereby increasing the ADR of efavirenz. What will be the ADR of efavirenz? We know CNS symptoms, that dizziness, somnolence, insomnia, confusion, hallucination, agitations. Also, it will cause rashes. That is about efavirenz. And nevirapine. Nevirapine also it can cause hepatitis if it is given within, like it will manifest within 12 weeks of administration. And the other things are other problems with nevirapine is that it will cause skin problems, skin rashes, which will go up to grade 4 toxicity, and thereby which can lead to Steven Johnson syndrome and also to TEN, that is toxic epidermal necrosis. Sorry. So this is the ADR of NNRT, guys. So let's go to integrase inhibitor, that is dolutegravir and raltegravir. Dolutegravir has a headache and insomnia as a major ADR. The patient will manifest. So we need to add more therapy to it so that it can be manageable. It's not, you shouldn't discontinue dolutegravir for those kind of ADRs. And again, raltegravir has some major ADRs like rhabdomyolysis, myopathy, myalgia, diarrhea, fever, rash, Again, same SGS and TEN, Steven Johnson syndrome and toxic epidermal necrosis, hepatitis, and hepatic failure. Then protease inhibitors, all of them have a common ADR. Those are GI intolerance, altered taste, abnormal LFT, and bone marrow disorder. Along with it, metabolic abnormalities. Metabolic abnormalities like hyperglycemia, insulin resistant, and increase in triglycerides, cholesterols, and lipodystrophy. So those are the main common areas associated with protease inhibitors. So that's all. Thank you.